Well, hello and welcome back. It is so hard for me to believe that we only have 3 classes left. That is so exciting. The course now is taking a little bit of a turn. We're getting away from mental health and now we are going to be discussing community health. Let's define what community is. So community is a collection of people who form a group. They often share common needs, concerns, interests, maybe characteristics, values, or goals. So community health nursing practice actually focuses on the health of the community as a whole. Now, we can provide care to individuals, families, but really the focus of community health is to that community or to a specific population. So what we're focusing on is the health promotion and health maintenance of that community. And we target these populations who are at risk rather than treating like episodic responses by an individual patient. So the practice really is a systematic process of assessment, planning, implementation, and evaluation for that population. It's a very holistic way to look at nursing, and the approaches to manage is the management of healthcare for groups. And again, the responsibility is to the population as a whole. So if we look at this slide, really nursing began as a community health practice, or what we would call public health nursing. So way back when, Florence Nightingale, as we all know, really is the founder of nursing, when she connected environmental factors to the health and well-being of the British soldiers during the Crimean War. And really this was the first target to a specific population, and that was the soldiers. Then as time passed on, we had another individual named Lillian Wald, and she founded the Henry Street Project. And really, she targeted the public health needs of the unemployed immigrants that were coming over for work. And so really, they were overcrowded, oftentimes homeless. So she provided care to this specific population in the public arena. Then, as we moved on in time, healthcare delivery really changed dramatically. And this was due a lot to insurance companies, where instead of nursing and doctors, I mean, way back when the doctors even went to the homes, switched to clinics and hospitals in which the population came to the healthcare providers. And now what we're seeing is that shift back to the community care. So we are seeing the length of stays in the hospital are decreasing. We're having more outpatient kind of treatments, and nurses are practicing in much more complex healthcare systems. And many nurses are meeting the needs of the population or the community outside of the inpatient setting. If we look at nursing, 40% of practicing nurses are now practicing out in the community settings rather than in the hospitals as it used to be. So Healthy People 2020 really focuses on this community-based kind of programming, where we're trying to look at preventing disease and injury, improving the health of the population and the quality of life. Healthy People also focuses on community-based programs, and these would be such settings as schools, workplaces, healthcare facilities, and in the communities. So we're going to talk a little bit about what is the difference between community nursing and community-based nursing. So this table here that I've created basically is trying to help you differentiate the difference between individual or family, as we see when we practice in the hospital or the clinics, and what community health nursing is. And I think we've kind of already talked about this, but basically population is the key factor, and really when you're in acute care settings, you're focused on that individual and perhaps their extended family in coping with illness, for that individual. Community health nursing, again, is focusing on populations of people. What diseases are affecting the general population, and what can we do about that? Assessment. Our nursing process is the same no matter what setting that we are in. It's just what we're collecting. So like for assessment, we're collecting information on that individual, right? We're doing a head to toe, we're checking vitals, that's that person's specific labs, and analyzing that data. When you're looking at community, what we are collecting is information on like a mortality, morbidity, disease prevalence or incidences in a population or a whole group of individuals. And then as you go down, you will see that as you do your diagnosis, planning, and interventions, it's going to be based on that population. So you may be doing things like setting up programs for a whole population, doing outreach education in the public arena, things like that. So that is the difference between community and acute care nursing. So what is epidemiology? Epidemiology is the science of public health nursing, and it refers to the study of the distribution and determinants of health related to a specific population and the application of this data to control health problems. So again, we're going to be collecting data, and we use the rates of incidence to recognize when there is a health threat or a disease encountered in a population. So we may be looking at measures of morbidity, which is the state of being diseased. So incident rates, the number of new cases, so that we can identify early that there is maybe some disease process that is starting, and start to investigate what the cause of that is and try and stop that. Prevalence rates are all of the existing cases of an illness at one given point in time. And so this is helpful in measuring chronic disease. So an example might be how many people with diabetes are obese. Okay, incident again is the number of new cases. So this is helpful in detecting and describing fluctuations or new onsets of disease in populations. So an example might be measles. We've recently had an outbreak of measles, so we may be looking at incident rate. So all of a sudden we have an increased incident rate of measles cases, which prompts us to investigate where is that coming from and how can we stop it. Another measure is mortality. So how many people have died within the population related to a specific reason. So one might be infant mortality rate. And why is that? Okay, and how can we stop that? Case-specific deaths, we look at those numbers, number of deaths assigned to a specific cause in a time period. So that might be traffic deaths. And sources of population-focused data for nurses includes information obtained from census, local, state, and national vital statistics and health statistics, okay? So we are going to be using the census. We're going to be using vital statistics, which is significant because it includes data of ongoing recording of births, adoptions, deaths, marriages, etc. So all of these I have posted on Blackboard. So we will be doing an exercise in which we're going to be using epidemiologic information to help us identify some issues. So this slide is depicting three models that we typically use when we are trying to determine disease causation. So after we have identified our epidemiological information and identified new disease or increasing disease incidence, we will use one or of these models to try and determine what is the cause. So there's several theories and models that can be used for disease causation, and the properties of each are a little bit different, and they work in different situations. So let's talk about the epidemiologic triangle. I think we're really quite familiar with this. Basically, this is what most public health nurses will use when they're looking at a communicable disease. So we may look at, again, let's use measles as an example. So measles, there's been an increased incident rate. So we have determined that the agent is measles. Okay, now we have to determine who's the host, or how did this get started, or how did this happen? And that is a really lengthy investigation, because what you do is you take your case who has the measles, and the public health nurse has to determine where that person has been, all the people they've been in contact with, and interview each and every single person to try and determine some common factor, to try and determine where this disease process began. Okay? And then once we figure out where it started, we have the information that we need, the environmental information, to determine how we can get this to stop. So getting these children in for treatment, getting people immunized, things like that. Okay? The iceberg model is a model that indicates that at any given time there are a small number of known cases of a disease. Okay, and these known cases are visible above the waterline. But the greatest threat comes from the greater amount of unknown cases, which is below the waterline. Okay, so what we do with the iceberg model is we do a screening attempt. So we try to screen and uncover the iceberg of disease. The aim is to reverse, halt, or slow the progression of the disease. And by screening, we can identify those undiagnosed or wrongly diagnosed diseases. The final one in the left corner is the web of causation. Personally, I kind of like this one because really it takes into consideration all of the factors that are going on. So the example given there is lung cancer. Well, lung cancer isn't only from smoking, is it? It can be from occupational hazards. It can be from hazards or pollution in the environment. It can be perhaps a hereditary link, or maybe it's related to diet. There's many, many factors that contribute to disease, and we need to look at all of these factors if we want to have any effects on the disease itself. So the levels of prevention. This is how we go about trying to influence disease processes. So primary prevention really is our target, and that is health promotion and health protection efforts. So we're looking to immunize so a disease won't happen. We're looking to educate people on how to change their diet so that they won't get hypertension. So it's those efforts where we are trying to prevent the disease from happening at all. Okay? Level 2 is the secondary prevention. This is really where we get into screening. So we're trying to identify people that have early health risks and trying to identify those people and reverse or halt the progression of that disease. So we might be screening for hypertension, and if we find somebody who has a little elevated blood pressure, we might be making changes such as educating them on the DASH diet and having them try that, or having them increase their exercise. Okay, so we're actually putting interventions into place, and then we are monitoring that person to see if we can get the blood pressure down. Right? So now and we would be doing the same thing if we are targeting a population. So if we have identified that cardiovascular disease is prevalent in our central Wisconsin population, we're going to be planning programming at these 3 levels. And our programming would be the same. So at level 1, we're going to have programming where we go out into the community and we educate, or into the schools and we educate, or we put public health notices on the radio or the television to educate people. Level 2, we're going to be going out into the public and having blood pressure screening drives where we're going to try and screen large populations. And level 3, the tertiary level, really this level is where somebody already has a chronic disease, and what our goal at this point is to maintain so that the chronic problem does not get any worse. So primary, prevent; secondary, screen and treat early to reverse; and tertiary is to manage an already existing problem. So just to talk a little bit about disease reporting and disease immunity. So all healthcare providers, labs, anywhere where you're doing any kind of health care, those facilities are required by law to report communicable diseases to the public health department. And we already kind of talked about then the public health nurses will investigate incidence and prevalence and try and stop the problem that way. So they divide communicable diseases into 2 separate categories, and basically it's just category 1 are the worst cases or the most communicable cases, and category 2 are not as dangerous, okay, or not as excuse me, likely to cause long-term problems. So category 1 would be active TB cases, measles, pertussis, things that can spread quite quickly in a population. Category 2 like STDs, tick-borne illnesses, things like that. Now, what I also wanted to explain is there's 2 types of immunity. Now, active immunity is if a person has had a disease and the body has fought it off and produced those antibodies to that disease. That is called active immunity. So they've gotten immunity because they've had the disease, or we've given them a vaccination that makes them immune to the disease. Passive immunity is really, it's like, the best way that I can explain it is mother to fetus. So the baby will have immunity from diseases typically for the first 6 months of life because the mother has passed on those antibodies. However, it's short lasting. Those will, like I said, 6 months will wear off, and the child then would need to get an active immunity through a vaccination. Okay? So what are our core public health functions? I think we've kind of alluded to many of these. We're assessing the population using epidemiologic data. We're trying to develop policies that will promote the health of the population. So we are monitoring epidemiological data. We're identifying problem areas. We're educating and empowering the population to be well. We're mobilizing partnerships in the community. Maybe it's a partnership with the Y. Maybe it's a partnership with the healthcare providers in instituting these programs, policies and programs that we want to put in place to protect the health of the population. It might be having a collaboration with the law enforcement. So if we're talking about environmental hazards, are we working with law enforcement and, to provide regulations on how much pollution companies can put out into the air? We're linking people to resources, and we're evaluating the effectiveness of all of the programming that we've tried to put into place. So let's talk a little bit about community health versus community-based, because it is quite different. Remember, community health is really population-based, okay? We're protecting a population. Community-based means a nurse is providing nursing care in the community. And an example of this would be a home health care nurse, which we'll talk about in a little bit. That is a community-based. So she's working out in the community, but really her focus is on that one individual or that family of that one individual and their health care, okay? Versus community health, again, was for a population, okay? So what are some core functions of community-based nurses? So it's just like when we're in the hospital setting, we're practicing out in homes, out in the community, perhaps in clinics, perhaps in rehab facilities, but really the nursing process is no different. And what we're trying to do is provide care for that individual or that individual's family when we're talking about community-based. Again, those nurses are going to be managers of that person's health care. They're going to have to collaborate with the doctor or the rehab staff. So we are doing many of those same functions as we do in the hospital, but the nurse is practicing in the home. Does that make sense? So an example of community-based, like we mentioned, home health care. So the nurse is practicing in the home with the individual and the family as needed for that individual's particular need. If it's rehab, or it's for wound care in the home, or it's for blood pressure monitoring in the home, it's still set on that one individual patient and that one individual patient's family. So a couple of things that I wanted just to address regarding home health care or community-based nursing. So community-based nursing is really a private pay kind of situation. Either it's through insurance or it's out of pocket, okay? So we have some eligibility criteria that the individual has to meet in order to get this care in the home. And typically for Medicare purposes, it's people age 65 and older, or people who are deemed disabled. So there's basically 3 criteria that a person must meet in order to get home care or get a nurse to come in and do home care. One is that there must be a skilled nursing need for the nurse to go into the home. 2, the physician must have deemed that person homebound. So example would be, so somebody could benefit from getting wound care in the home, okay? But if that person is not deemed homebound, that person could go to a clinic setting or a rehab setting 3 times a week and get that wound care done, or on a daily basis, whatever the need was. So to qualify for home care, they have to be deemed homebound, okay? And then they have to, again, have a skilled nursing need, and they have to be deemed disabled or be an elderly person, 65 and older. Oh, I'm going to go back. There were a couple of things that I wanted to mention regarding home care that's very important and a little bit different for nursing, okay? Home care is, we have to be very cognizant of infection control in the home. So you can think the nurse is going into the home and providing care in an environment that is not controlled. Like in the hospital, that environment is controlled. We know that our supplies are sterile. We know that our environment is clean. However, when we're going into a home setting, we don't really know how clean that environment is. So we need to put in some extra infection control practices. So that would mean when we come in with our bag, and we have our supplies in our bag, we know our bag is clean, we know our supplies are clean, but then when you enter that environment, you really have to provide a barrier between the environment and your supplies. And that's easily done by bringing a drape along, putting the drape out, and then putting your supplies on top of the drape to maintain sterile conditions. Hand washing is going to be very, very important. Decontamination of our equipment and supplies upon leaving is going to be very important. Our personal supplies, such as our coat, we want to just be leaving in our car so that we are not carrying contaminants out of the house on our personal person or our personal possessions. Okay? We want to be wearing a uniform that can be cleansed. Other things to be careful about is make sure to lock your car. When you're in the home, you don't know what's going on outside of the home. Watch for animals. People might have pets, and you don't really know if they're friendly or not friendly, or maybe they're friendly but not to strangers. So be very careful about animals that might be at the home environment. Always knock and wait before you go in the home. It is their personal home. Visit during the day. Do not visit during the night. That causes other concerns for safety. Make sure that your agency is aware of your schedule so they know where you are at all times. And always make an appointment with your client or your patient in the home. Okay, so let's talk a little bit. Another community-based nursing practice is home hospice care. And again, the goal is to provide quality of life care to somebody who is terminally ill. To qualify for home hospice care, again, they have to meet specific criteria. One is that they have to have a diagnosis where their life expectancy is less than 6 months of time. Again, typically they are deemed homebound. And so the nurse can come in and provide services in the home. Now, there is a difference between palliative care and hospice care. Palliative care means that the person still may be attempting to treat their disease actively. Okay? Hospice care is where they have decided that treatment is fruitless and have gone to comfort care only, just keeping them comfortable. So a person in palliative care might be somebody with cancer, and they're still receiving chemotherapy treatments to try and get that cancer to go into remission. Hospice, again, hospice care is that comfort care. The nurse is going to be providing education to the family and the individual on the dying process, providing pain medication management to keep that client comfortable and ease the transition for the family members. So I think that's kind of self-explanatory. And that's the end of this lecture. Next week we're going to be moving on to environmental factors that contribute to public health nursing. So we'll see you next time.